Chronic post-sternotomy pain syndrome, or CPSPS, is a long-lasting pain condition that can develop after major chest surgeries, especially those involving a sternotomy. While acute pain is expected after surgery, for some patients discomfort persists for months or even years, affecting their daily lives. This syndrome is often underrecognized, yet it can significantly impact recovery, rehabilitation, and overall quality of life. Understanding what CPSPS is and why it happens is the first step toward better care and prevention. In this video, we'll explore the definition, causes, risk factors, and the latest management strategies for CPSPS, helping patients and caregivers navigate this challenging complication. CPSPS is more common than many realize. Studies show that up to 1 in 5 patients may experience moderate to severe pain a year after their surgery, and a smaller group can suffer for several years. The numbers vary widely, with some research reporting prevalence rates from 7% to as high as 66%, depending on the type of surgery and how long patients are followed. This persistent pain isn't just a minor annoyance, it can interfere with sleep, mood, and the ability to return to normal activities. Recognizing the scope of the problem is crucial for both patients and healthcare providers, as it highlights the need for ongoing support and better pain management. Not everyone who undergoes a sternotomy will develop chronic pain. Certain risk factors make some patients more vulnerable. Younger age and female sex are linked to higher rates of CPSPS, possibly due to differences in pain sensitivity and hormonal influences. Other factors include obesity, a history of smoking, pre-existing chronic pain, and psychological distress such as anxiety or depression. Surgical details also matter. Longer, more complex operations, internal mammary artery harvesting, and repeat surgeries all increase risk. Even poor pain control right after surgery can set the stage for chronic pain. Identifying these risk factors early helps tailor prevention and treatment strategies. CPSPS develops through a mix of physical and nerve-related processes. The initial surgical trauma to bone, muscle, and cartilage causes nociceptive pain, while nerve injuries, especially to the intercostal nerves during sternal retraction or artery harvesting, can trigger neuropathic pain. Scar tissue and sternal wires may also entrap nerves, leading to ongoing discomfort. Over time, the nervous system can become overly sensitive, a process called central sensitization, which amplifies pain signals. This combination of factors explains why pain can persist long after the surgical wounds have healed and why it can be so difficult to treat. CPSPS is most often linked to cardiac surgeries that require opening the sternum, such as coronary artery bypass grafting (CABG), valve repairs or replacements, and aortic procedures. Harvesting the internal mammary artery during CABG is a particular risk for nerve injury and chronic pain. While lung surgeries are usually performed through other approaches, certain cases like bilateral lung transplants also use sternotomy and can lead to CPSPS. Other less common procedures, such as thymectomy or mediastinal mass removal, may also result in chronic pain if a sternotomy is performed. Understanding which surgeries carry the highest risk helps guide prevention efforts. Effects of CPSPS go far beyond the initial pain. In the short term, severe pain can make it hard for patients to move, breathe deeply, or recover quickly, sometimes leading to longer hospital stays. Over the months and years, chronic pain can disrupt sleep, cause mood disorders like depression or anxiety, and limit daily activities. Many patients find themselves relying more on pain medications, which can bring their own risks. The overall quality of life, physically, emotionally, and socially, can be deeply affected. Recognizing these long-term consequences is essential for providing comprehensive care and support. Managing CPSPS requires a multimodal approach. First-line treatments include non-opioid pain relievers like acetaminophen and NSAIDs, with medications such as gabapentinoids and certain antidepressants used for nerve-related pain. Opioids are reserved for severe cases due to their side effects and risk of dependence. Regional anesthesia techniques like thoracic epidural or paravertebral blocks can help control pain and reduce opioid use, especially when started before surgery. Newer options, such as erector spiny plane blocks and parasternal blocks, are being studied for their effectiveness. The goal is to tailor therapy to each patient's needs and minimize long-term pain. Patients with persistent or severe CPSPS, new therapies are being explored. Interventional options like subcutaneous peripheral nerve stimulation and percutaneous cryoneurolysis show promise for those who don't respond to standard treatments. Non-pharmacologic approaches, including cognitive behavioral therapy, acupuncture, and osteopathic manipulative treatment, can also help manage pain and improve function. These therapies may be used alongside medications and nerve blocks to provide more comprehensive relief. Ongoing research is crucial to determine which combinations work best and to develop new strategies for prevention and treatment. Preventing CPSPS starts with identifying high-risk patients and optimizing pain control right from the start. Multimodal pain management, early use of regional anesthesia, and close follow-up can all help reduce the risk of chronic pain. A multidisciplinary approach, bringing together surgeons, anesthesiologists, pain specialists, and mental health professionals, offers the best chance for recovery. As research continues, new therapies and preventive strategies are on the horizon, aiming to reduce the burden of CPSPS and improve long-term outcomes for patients undergoing major chest surgery.